Good afternoon, everyone, and welcome, welcome. Sure, it's a little bit cold here in Centurion this afternoon. Hopefully, wherever you find yourself, you are wrapped up nice and warm, hopefully with a cup of tea or coffee, or even a little something that is a bit more readily available now that we are in lockdown level 2. I'm just wondering, while I see, all the numbers climbing, how many of you, A, have been to the gym? Have you perhaps crossed a provincial border? Or are you just responsibly planning a little get-together either for friends or family this coming weekend? I honestly hope so. Whatever you do, one thing that I believe in, big or small, do it well or don't do it at all. A warm welcome to you again all this afternoon. I believe we've got, very close to 700 people that registered. We've got 20 disciplines today. I believe we've got a homeopath that is also joining us today, so very, very welcome. I can tell you that we've got close to 250 psychologists. We've got over 40 registered counselors. There's over 100 physiotherapists, occupational therapy, 71 of you, just over 50 biokineticians. We've got 50 speech therapists and audiologists. Around the same number, 20 dietitians and podiatrists, close to 30 medical orthotists and prosthetists, and then there's social workers, chiropractors, a whole handful of optometrists. We've got phytotherapists joining us again today. There's 3 hearing acousticians, and there's also registered nurses. So an absolute warm welcome to each and every one of you. Perhaps just while you're busy settling in, do remember that you can join in on the conversation by either using the chat functionality or the Q&A functionality. You can find that at the bottom of your toolbar. And just join in, ask questions, and we will hopefully get to all your questions, or as many as possible. Just a reminder, this is a follow-up session from our first session, which took place 2 weeks ago. I think it was on the 6th of August, if I'm not mistaken, with regards to our conversation on ethical diagnosis coding, or ICD10 coding. And should you be interested to go and watch that session or any of our previous sessions, it is available on our website. So if you log on to EZMed.solutions, navigate to the webinar tab, and you can actually find it there. I did ask my colleague Yolandi to just share all the different URLs where you can find these webinars. And this ranges from our website. It takes you to the YouTube channel. There's a podcast channel as well as Spotify. So you can find it in the chat box. Please copy and paste that. If you've got a bit of time, do go and visit, listen, and watch any of our previous webinars. To give you an idea, just last week, we had EZMed with us. Now, she's a registered attorney, and she specializes in health law. And she literally took us through the A to Z of the new POPI Act. That was promulgated not too long ago, and the implications that it will have on all of us, you, your practices, and your patients. So even that webinar is available for you to go and listen to. We are yet again very grateful to the SpaceNet Global Group for sponsoring this event today, and this is with the support of EZMed, the sophisticated practice management solution, and Medici, the secure telehealth platform. And as you know, both of these magnificent products are still free to use up until the end of August. So should you feel either you or your patients would need an extra hand or an extra helping hand by using these 2 products, please just contact us via the EZMed.solutions website. Oh, and again, we managed to get this webinar accredited for One Ethics CEU. So your certificate should reach you via your email address early next week. So today, like I said, we're continuing our talk on ethical diagnostic, or ICD10 coding, and we've got an all-girls team here again today. Yolandi, Arna, welcome, and thank you again for joining us. Arna, I think a lot of people joining us here today would know Arna from the coding world. She's been in managed healthcare since 1998, if I'm not mistaken. She spent 14 years as a national clinical coder at the Netcare Group. And she's also a certified professional coder, and she got that qualification from the United States. So extremely well qualified to come and talk to us today about ethical diagnostic coding. Yolandi Potgieter, very, very close colleague of mine. She, same as with Arna, she's been with the SpaceNet Global Group for 5 years. And Yolandi is the absolute heart and soul of the EZMed training team. She's got a wealth of knowledge and heaps of experience in practice management. And she was actually a practice manager herself in numerous disciplines. So if there's someone that you need to talk to about anything that happens in your practice, Yolandi's the person. So Arna, Yolandi, thank you again for joining us.
Pleasure.
As you know, my name is Lani Ace, and I'll be your host again this afternoon, and I'm a product manager with the SpecNet Global Group. Now, even though both these lovely ladies are extremely well qualified with what they're doing, please just remember, and it's just a little disclaimer, that we are having a conversation around this topic of ethical coding, and it is literally just our opinion. Should you require a professional opinion or some competent advice, please do contact a competent advisor. Again, we're just having a comfortable and a conversation this afternoon. So, and please join in. Like I said, I think there's more people that joined us now. If you want to chat with us, please use the chat functionality or the question and answer functionality. I do believe we need to kick off. It is 4:05. I see the numbers are still rising, but please just join us and make yourself comfortable. So 2 weeks ago, I asked the question, why do we have to code and use ICD10 coding in our practices? And I think Arna summarized it so nicely that there are two things you need to take in mind. First of all, it's a legal requirement as stipulated in the Medical Schemes Act. And secondly, the other requirement is more around ethics. So we've got an ethical requirement as well. And this involves the need for clinical research, health resource allocation. We're thinking about statistics. We're thinking about education, auditing purposes, and medical billing, which you as healthcare providers know is so strongly related and linked to reimbursement. And this is literally just to name a few reasons why we need to code in our practices. But as healthcare practitioners, we've also got a responsibility to code as accurately and ethically as possible. And we will definitely go into more detail around that today in this webinar. I'm also going to ask Yolandi in just a few minutes' time to show us some examples around coding, and we're going to address those two ICD10 COVID-19 related codes, which we touched on just last, or 2 weeks ago rather. But before we get to that, Arna, there's something that I need to talk to you about. What is it and who does it apply to? And I'm referring to this clinical code of conduct.
Okay, I'm going to start with a friend of mine. She lives in America, Ellen Fink-Samnick. And she says that ethics, and I'm now just reading quickly what she's saying. Okay, ethics is one of the items that should be included in your diet, no matter what diet you're on. Okay, same story. Ethical coding and clinical coding and how you do it needs to be applied no matter who you are and what practice you are. I hope that in very briefly answers what you're asking. She also says that ethic is what you do while others are watching you. And if we start thinking of that, we tend to code differently. We tend to code more accurate. So yeah, it's relevant to each and every single person.
And am I correct when I'm saying, when we're talking about ethical coders or clinical coders, everyone who treats a patient, creates an invoice or a claim, submits it either to the patient or to a medical scheme, they are clinical coders. And they need to try and adhere to this clinical code of conduct.
Yeah. The 9 clinical coders can actually be divided. There's two things. Primarily, you as the provider is the clinical coder. But when you have people that's doing it for you or that works with that coding, they fit into that clinical coding umbrella at the same time. So they're not excluded from then becoming a clinical coder at that point. So
it might be a practice manager who's the coder and not necessarily a healthcare practitioner or a registered healthcare practitioner.
Yes. The important thing is that if it is not the healthcare professional themselves, then it is the responsibility of the professional to make sure that the staff member that's going to do the coding for them actually do understand how to code. So while you understand it, you can't expect from somebody else to do your coding if they do not have the knowledge on how to code. So then you need to send your practice manager for training.
Sure. But doesn't the conduct also address things like the fact that you shouldn't be exploiting the coding for commercial gain?
Yeah, you know what? The one thing that, if you look at the clinical code of conduct, that we need to understand is that this conduct is not just about ICD10 code. And I know we're talking basically on ICD10 today, but ethics on coding goes around whether you're using your ICD10 coding, whether you're using your RPL codes, whether you use your CPT codes at a hospital level, whether you use NAPI codes. It doesn't matter. It's relevant on all types of coding. And one of the last point in the clinical code of conduct is indeed stating that you are not allowed to exploit coding for undue commercial gain.
So perhaps you just elaborate on that a bit.
Yeah. A silly thing, I know of a medical scheme that, for example, did an audit on a practice, and there was like 24 sessions booked, or 15 or 42. It was a lot. Okay, how many 15 minutes can you put into a day? And when they really did the investigation, she saw about 5 patients, 6 patients, and there was consultations that was repeating where patients wasn't seen. So she billed these patients, and they were actually, there was ICD10 coding or RPL coding, but there were no patients. That's extremely unethical. It's, as a matter of fact, fraud.
Yeah.
So when we code, we need to remember that medical schemes has very powerful software. Okay? If you code unethically, they are going to pick it up. If you code for undue commercial gain, you can get away for a while, and once there's a trend, the medical scheme will pick up the trend. And they're going to do an investigation and say, what's going on here? The coding doesn't make sense. Say, for example, you see patients with depression. Surely, if you're a psychologist, not all the patients in your practice has F32.9. Depression unspecified.
Yep.
It's a PMB, that's cool, but it's not necessarily what's wrong with the patient.
Yeah. But surely when you start talking what's wrong with the patient, you need to code for the patient sitting in front of you.
Exactly.
So not for, in general terms, not for the benefit of trying to unlock a basket of funds at a medical scheme, for example.
Yes. You know what, there's a lot of times requests from providers to say, please can I have a PMB code? It's not about whether it's a PMB or not. I know we want it to be PMBs, but that is not what it's about. Because at the end of the day, a PMB equals threatening life or limb. But that's really what it is. So we must be very careful not to upcode our patients and then it bills incorrectly. Have you ever thought of the change that you can make in a patient's benefit if you assign a cancer code? It can be unintentional. You say the patient's got a cancer code, C50.9. In the meantime, it should have been a benign neoplasm. It should be a D50.9. Immediately, you've changed the patient's whole benefit structure in this medical scheme. If that patient goes to another medical scheme, he's going to be underwritten for something that he doesn't have. He's going to be investigated for something that he didn't have. So we must be very careful when we assign our coding. It must be a true reflection of the information in your patient record.
So not only is something like that not ethical or unethical, I think it's just extremely unprofessional as well.
Absolutely. And you know what? The biggest culprit of that is we actually don't think about this. We think, you know what, these 10 codes on this little list, that works. It will get my accounts paid. And you start using those because it gets your account paid. It's sort of close by, around about what's wrong with the patient, so let's just use it because we know it works.
Mm-hmm.
And in the meantime, there could have been something totally different. If you know that schizophrenia or psychosis or whatever is also a PMB, then you don't code it as a depression.
Yeah, yeah.
But if the patient is seeing you for some unspecified anxiety, I'm not thinking of these examples at the moment, and it's not a PMB, you can't bill it as a depression.
Mm.
So we need to be very careful, because ultimately your practice builds up a record at a medical scheme where they can trace exactly what you are coding.
Yeah. And I think, Adna, a lot of the medical schemes, I mean, they're sitting on a lot of data, obviously. So they gather all this information around the ICD10 codes that healthcare professionals are using. And they can use that information as part of their benefit designs. Now, that can either be, you know, a positive or a negative thing for a healthcare professional, depending on what sort of ICD-10s they're looking for. So if you as a healthcare professional are not coding correctly and within the clinical code of conduct, the wrong message actually reaches the medical schemes.
Absolutely. You know, I've always compared coding with, you know, when you look at the children's, those coloring books with the numbers 1, 2, 3, 4, 5, 6, 7. You know? If you buy a bad coloring book, you open it, you have no clue what the picture is. Okay? If it's a good coloring book, you as a mother can see, okay, I know this is an elephant. Okay? And the child will draw the little elephant, and then they know it's an elephant. And our coding is the numbers that make it possible for the medical scheme to paint the picture, to draw the picture, to enable people to pay claims correct.
Yeah, so the only thing the medical scheme can do at the moment is with the information in hand, and they paint by numbers.
You know what, if they ask you for a motivation letter, we all hate motivation letters. There's not one provider that can say to me they love them. Okay?
Yeah.
If they ask a motivation letter, one of the numbers in the picture is missing. That's why they're asking.
Mm-hmm. Something else that I just thought of is, obviously there's numerous healthcare professionals that actually work together, or they inter-refer amongst one another, or they work in a hospital environment together. If someone picks up that another healthcare professional is, according to them, coding unprofessionally or unethically, do they have a responsibility to report that?
Absolutely. You know what, and that is very scary, because the code of conduct actually say raise matters of unprofessional coding.
So who do you raise it to? How do you approach that?
There's various things to do. I mean, obviously, I do believe in the principle of, you know, just tell the person this is not on. This is not supposed to be done. But very often, when there is a hierarchy in authority, when lower hierarchy people pick it up, they are a bit afraid of telling the hierarchy person, you are doing this wrong.
Do you see
so there is different ways of reporting it. You can approach, if you go and look at the data of medical schemes, patients report it to the medical schemes. Other providers report it to medical schemes. They can report it to the Council of Medical Schemes. There's a lot of places where you can be reported and ways in how this can be dealt with.
Okay. I think you sort of touched on an example where, let's say there's an old hand in a practice and they've coded a certain way for many years, and there's another clinician that comes into the practice and they've got a different way of coding. And like you say, with the hierarchy, someone else might be telling you, but you need to code X, Y, and Z in your practice. And it's challenging to take on let's call it a senior person, or any person for that matter, that is coding according to you incorrectly.
Unfortunately, you know, that is, ethics is one of those things that differs from one person to another.
Yeah.
It's something that you learn when you're very small. and it's a choice. We need to remind ourselves of that every day. So, you know,
what I'm really hearing here is that when it comes to ethical diagnostic coding, is that honesty is just the best policy.
It is, absolutely. You know what, and it also goes for your procedural coding.
Yeah. With any
and
coding,
your NAPI codes, the stock items that you charge on your if you've built it. How many times do you repeat the code? Do you not repeat the code? You know what you need to put. Your coding must be 100% reflection of the patient.
You mentioned 3 types of code now: procedure coding, NAPI coding, and ICD10 coding. There is a question that came up. What is the difference between those 3? I know we touched on this last week, but maybe just in one sentence, if you can explain to the attendees, please.
Your procedure code is your billing code. That is what you are physically doing to the patient. What are you doing as a provider?
Also RPL, because I think RPL.
Yes, or your billing code. Okay. Then ICD10 coding is what is wrong with the patient, the diagnosis of the patient. Okay. And the NAPI codes is the different stock items. If you use a needle, syringe, web call, that's stock items. And those stock items all have NAPI codes and a price tag attached to it.
Okay, I think that summarizes it nicely. Thank you. Let's leave it there. Guys, just quickly, another question that came up. It is a question that came up last week. I do want to answer it because I actually asked for some advice here. May a medical scheme share ICD10 codes with an insurance company, like a life insurance company, for example? The answer to that is, and I actually spoke to an attorney about this, they can share it as long as they have consent from the patient. Otherwise, no. So I'm going to leave it there. I'm not an attorney. I'm not a specialist with this, but I did ask specifically with regards to that question. I did ask for some help there. Anna, we started talking about a few, let's call it top 10 tips last week, or 2 weeks ago rather. And we sort of ran through some of them, which include don't use cheat sheets, code to the highest level of specificity. Now, I know you've got your top 10, and I want us to briefly, from 1 to 10, go through these. And attendees, we will be sharing quite a few documents with you after this webinar. We're going to attach it into the webinar link of today's session. So you can write it down, or you're going to find it there by tomorrow or the day after, but we will definitely share everything with you, including Arna's top 10 tips. So Arna, fire away. Tip number 1.
1, don't use the internet, okay? Don't you ask Dr. Google for codes. You're going to end up in American ICD10 coding with 7 characters, and the medical scheme is going to reject your account. If you want coding, you use a proper platform, electronic solution, or a PMA, or you use the Excel spreadsheet, or you use the books. That's the 3 options.
No cheat sheets.
No cheat sheets. If you don't understand the books, they're costing $600 a set. It's challenging to get those books, and they get little feet. If you use the Excel spreadsheet, you are going to run into a scenario where you can't see the rules of the guidelines. You can see fixed rules, like, yes, this is a primary ICD10 code, but you might not be able to link a dagger and asterisk codes with each other, for example. It's also not automatically linking your S and your T codes with external course codes. Okay, we'll talk about that a bit later. The other thing is code to the highest level of specificity. We've already said it. We've said the cheat sheets. Think with your Trump hat on.
Oh, this one you need to explain.
Politics work today, okay? Trump is in the news. If you start spelling and coding, it is best to spell with your Trump hat on, should you make use of looking up an ICD10 code through an index.
So that's the American way of spelling things.
Yes. If you, however, look up a code using the tabular, just a long list of codes, okay, that was put together, the way that it's struck, where it's on our personal system on the PMA, there you actually make use of the British English. So there's a small difference between looking up an esophagus and an esophagus. If the one don't work, then you try the other one. Okay, it can be both. Right. Then never use an anatomical site to look up a code. If you look up femur, you're going to find 1 million codes for femur. You need to look at the word that you need to use when you look up a code is the broadest descriptive word of what is wrong with the patient. Okay.
So if you use femur, there's nothing wrong with just using femur. Like, what is wrong with a femur?
You might find femur. You're going to find it, but you're going to fish in a big pond to get to the correct code. The moment that you look up fracture primary, you can do alphabetically go to femur. Or if you put in fracture femur, you're going to have more information. But be careful not to use the anatomical site as your way to look up ICD10 codes. Okay.
Good tip.
Age and gender. Coding is linked to age and gender. Okay. When you look at your age, brackets, keep in mind that in the hospitals, the pediatric ward is up to age 12. Very often in coding, it is up to age 15. Okay, so you need to read the notes in your coding to see whether it's a child or an adult. So you find this, for example, in bronchitis coding, where the physios can have that challenge. Okay, then your S codes and your T codes, that's your injury and your cause codes. And Yolandi is going to show you examples about it. Your injury codes, if a patient injured themselves, it is compulsory to always have an external cause code with it.
And that's your VWX and Y.
VWXY codes, yes. If you don't put it in, it's rejecting.
Yeah.
The other thing is, if you have a dagger, an asterisk combination code, if you put your asterisk code first, your account will reject. You must put your dagger code first. Okay? Don't unbundle unnecessary. Appendicitis, you will have abdominal pain. Don't code both. If you diagnose the patient initially with, say, for example, the abdominal pain, that's fine for your first claim that you send in. But now there's a diagnosis. You've done the investigations, you've done the tests. Now you know, okay, you know what, this patient is actually not just depressed, this patient's got psychosis. Your coding can change. Your next claim, different codes. Okay. Or abdominal pain, different code, appendicitis.
And that should be accepted by the medical schemes.
Well, yeah, it should be. Okay. I have seen medical schemes that can be a bit difficult about it, and it is because they've authorized the primary one. But in the South African standards document, and that's one of the documents that we will attach for you, you will find that there is actually rules that say a primary diagnosis, a complication or a comorbidity may become the primary diagnosis. So it's the government say it can. You can change your coding. Okay. So it may, as the patient progresses, your primary diagnosis can even be your highest cost driver. So you might treat the patient now for one thing, and ultimately there's a totally different problem costing a lot of money, then that one can become the primary diagnosis. Okay. Do not code just for the sake of PMB. Okay. It's really, guys, look up the diagnosis, write the diagnosis, code what is wrong with the patient. If it is a PMB, bargain. Okay, we must really be careful of doing that. It is very unethical to code just to do that. And then, just make sure that you have the correct diagnosis. And if you use somebody else to do your coding, please write properly. You know what? If it's non-clinical people, they don't understand necessarily medical abbreviations. Unless you tell them and you make them a little list and you train them, that's fine, then they will understand what you are writing. But, when you write bronchitis and atelectasis and psychosis and you write a lot of stuff, non-clinical people will not necessarily understand what you are writing. Here's a tip that's not on that list. If you have a lot of information in your patient report, you see this thing, it works, a yellow one, not the others, the yellow ones. I like
One
the
too.
reason for it. Okay? I like the diagnosis for your staff, if they do the coding, so that they look at the right stuff, that they code, that they know what to code.
Yeah.
Because if a administrative staff see a document that is 5 pages long with all the clinical notes, you know what is there truly. She doesn't necessarily even understand this. She's going to capture it on the system, and now between all of this, she needs to decide what's the diagnosis.
Yeah.
So that's my biggest tips.
It's now your top 11 list of tips, not top 10 anymore.
My top 11 lists. Please add the highlighter.
There's a question that came in. I mean, talking about what you can code and can't code. There are some allied disciplines that are not allowed to diagnose. And for instance, there's a patient that comes with a problem. They've potentially seen another healthcare professional. How should that discipline that can't diagnose do the coding?
Okay, here's the challenge that you have. Very often those practices, their coding will probably not be BMB. Okay? You need to code what you are doing. So if a patient has difficulty to mobilize because he has been for hip replacement. Okay, this was maybe not a good example, but the mobilization is the problem. He's out of hospital already. Now he needs mobilization exercises. You can't code the fact that the patient had a fracture because now it's not active anymore. If it is still in that acute phase of treatment, your doctor codes can become secondary codes. You're still going to code your mobilization, difficulty to walk, fracture femur after car accident. But you can't put the fracture femur first. Because the doctor is going to look at that. But it is important motivation for difficulty to walk. Because if you don't code the difficulty to walk, they don't know what you're doing.
Or what you
Why are you doing it? You're mobilizing, you're putting the billing code, you say the patient has difficulty to walk. Why is he difficult to walk? He's difficult to walk because there's a fracture of the femur and a car accident. Okay. So your doctor codes almost become your secondary codes.
Okay. I think that explains it nicely. I want to talk about ICD10 codes that doesn't exist yet. But two codes that we know do exist, and fairly new codes as well, are the COVID-19 codes. Yulani, I'm going to look at you in just 1 minute. Then we're going to show some examples. But Anna, how do new ICD10 codes, where do they get born? How do they come into play and in existence?
It's a long thing. Okay, I actually had somebody that asked that with English Week said, oh, they've decided to use a new code, Euro7, for history of COVID. And myself and Louisa at Discovery almost got heart attacks because of it. No, we can't do that. Okay, codes are formalized first and foremost by the WHO. There's a list of U codes at the moment. Okay, emergency, all of them is written emergency use, UO7, UO8, UO9, things like that. Then when something like COVID happened, they decide we're going to use UO7.1 going forward as the code for COVID positive. We're going to use UO7.2 for a clinical diagnosis not confirmed. Okay. They did that, for example, recently with Zika virus, with when SARS came in, and then those U codes are over time phased into other parts of the ICD-10 book. It will probably go into ICD-11. I don't think it will stay in ICD-10. It will always be a UO7 code for that specific. Okay. So there's also a small group of codes, also U codes, that is identified for country-specific codes. Now, the multiple resistant tuberculosis codes for South Africa sits in that section. But what then happens is that the Department of Health primarily is responsible for it, and then they work with the FISC, where the Private Health Information Subcommittee, and then they will decide, okay, this specific code can be used for South Africa.
Okay.
And then only a communication will go out to the industry to say, there's a new code, and this is what will be used. South African codes has not changed since 2014, with the exception of the 2 U codes for COVID, where we just adopted they were in the system already. We just adopted the description of the codes.
Okay. Thank you, Arna. So perhaps just to remind all the attendees, we did address this and show this to everyone 2 weeks ago. I keep saying last week, it's not last week. Yolandi, do you mind putting up the practice management system and then just indicating and showing to the audience those 2 codes? Let's start.
Just enable me to share quickly.
Ah, you ask so nicely. There you go.
Thank you. Okay, so thank you, Lonnie and Arna, and I'm going to show you exactly what we just talked about, especially in a PMA system. So I've actually searched for COVID in my PMA system that I'm using here, and you will see I came up with 2 options. Now, what you actually need is, first of all, if you look at the code, virus not identified, it says it is a PMB. If I click on the PMB, it should show you treatment pairs. Okay, at the moment there isn't. If I look at the notes, it gives you more details. All right, and then you get a COVID-19 virus identified. If I want to, I actually want to sketch a scenario for you. So let's say I'm a psychology practitioner and I'm seeing a COVID-19 positive patient who is extremely anxious and concerned about his health, family, and well-being. He has to self-isolate, which means that he needs to move out of his home. He's self-employed and concerned about losing his contract and financial outcome. How would I code this? So first of all, I'm not a coding specialist, so I'm just going to go and say, listen, this is COVID-19 related. I'm seeing him for an assessment or a counseling session to help this poor guy. And I'm going to say the virus is identified. I'm going to add my diagnosis to my PMA system. And now I obviously want to add my procedure code or RPL code that Arna explained what that is. So if I add my procedure code for counseling, what I want to show you is I have actually got a warning that says this is invalid for the diagnosis. The procedure code is invalid for diagnosis, but I'm seeing a patient for COVID-19. How is that invalid? And that is exactly what Arna was stipulating, is that we need to tell a story of what am I treating actually here? I'm not treating COVID. I'm treating the patient for an anxiety disorder, and he's going to lose his job, and he's got a whole lot of things happening there. So what I want to show you is if I change this ICD10 code and I go dive a little bit deeper into the coding structure, and I type F41.3, I'm going to show you now. It says other mixed anxiety disorders. If I go to my notes, it will tell me symptoms of anxiety mixed with features of other disorders. Neither type of symptom is severe enough to justify a diagnosis if considered separately. Right, so if I code that, and of course I need to tell a story, I'm going to add a secondary code, and I'm going to say, okay, he's also scared he's going to lose his job. So I put in the threat of job loss. If you didn't know, there's an ICD10 code for that. Now you know. So I'm going to add that. And then, of course, the COVID one. He is having this condition because he is COVID positive. So I'm going to say 07.2, which is not the right one. Let's put it 1. Virus identified. If I add it there, you will see my procedure code does not have any warnings. And this is exactly what you need to ask yourself. Does your PMA system actually guide you with regards to your ICD10 coding, your procedure coding, discipline specific as well? So it assists every practitioner out there on how to bill ethically. So Anna, does the same principle apply to other disciplines where COVID is not the primary diagnosis?
Yeah, yes, absolutely. So whether you're a bio, whether you are a psychologist, whether you are a physiotherapist, that's the principle that applies. Okay, that is how it should be coded. You are 100% correct. And if you don't have software that support you in it, it becomes difficult to be ethical.
Definitely.
Yeah.
Okay, so I mean, just to sort of recap what I heard from you there, Yolandi, if you are in any discipline, you are treating a COVID positive patient and you are not actually treating the COVID, you are treating the after effects, the side effects, the psychological effects, the physical effects perhaps even, because you strained your back because you're working from home, because you were sitting on an apple cart or something like that. You can still add COVID as a secondary code, ICD10 code, but your primary will rather be either the mental health code or the physical code, etc., etc.
Lonnie, it's perhaps also important to mention for those that are interested in the COVID coding, if you look at the documents that we're going to attach, one of them is the FISC addendum to ICD10 coding. And round about page 28 to 43 is examples and information about how to code COVID. So the fact of the matter is you code as a primary ICD10 code, the US7 for COVID as a primary, will probably only be relevant for the doctor, whether it's a GP or a specialist, doesn't matter, for the doctor, and then on the hospital code. It can be positive there. But even for the hospital, if the patient was admitted for something else, but the patient is also positive, it doesn't mean that the COVID is going to be coded first. It's going to be the fracture because it was in a car accident.
Sure.
Okay. Yeah.
So just those two codes again, it's U07.1, that is for COVID-19 virus identified, and U07.2, COVID-19 virus not identified. Those are the only two codes that we can use for COVID-19, because there are numerous other COVID viruses out there with other coding sets for them.
Absolutely, there's other COVID codes. Please don't use them for COVID. Or there's other Corona codes, if you say it that way.
Corona codes.
They are not COVID codes. Yes.
Excellent. And another quick question for you. So this is questions that we got during the previous webinar, and I see it actually appeared here again. Is there a specific ICD10 code set, and where can I get it, which relates to my specific discipline, whatever that discipline is, whether it's psychology, physio, bio, speech therapy, it doesn't matter?
Okay, the first important thing that I want to say to you is that there is not a psychology, a physiotherapist, a biokineticist, a nursing set. There isn't something like that. Okay, and I've heard and I've learned this question a lot. No, there isn't something like that. You get ICD10 coding. It's a group of diagnostic codes that may be relevant in various different ways on various different patients within the same practice. Okay. So if you have, for example, a patient, you're a psychologist, you're seeing the patient for post-traumatic stress, she was raped, you need to know how to code, yes, the post-traumatic stress, but you need to know how to code rape and the fact that she was, the actual injury to the patient and the fact that she was raped, the S and the T code, so it's 3 codes. And you will need to know all 3 of the sections and how to put those codes together and how to look it up. And if you don't know this, you're not going to code it. And then people tend to think ICD10 coding is an Excel spreadsheet and I can have a little piece of it. Okay. Yes, in software there is an Excel spreadsheet. It's called the Master Industry Table. It is mainly there for software companies to put it in the back of their information, for medical schemes to put it in the back of their information. Many practices make use of the Master Industry Table because that's all they have. If you know the Master Industry Table and how to interpret and read it, and you understand coding, then knowing what's going on there is easy. Okay? Yeah. But if you don't understand it, and you don't have rules and guidelines, Yolandi showed you when you look up your 7.1, you can put it perhaps up while I'm talking. When you look at your 7.1, okay, there is a guideline that would say to you, notes. Those note information is vital because there you actually read guidelines and rules on coding. And that you will never, ever, ever see in an Excel spreadsheet.
Yeah. So whichever structure you're using, it should try and incorporate the rules, the guidelines, the notes behind which code can or cannot use with another code.
Exactly. You know, there's nothing in the Excel spreadsheet, for example, that would say that this is a valid S code, but I'm using it, it's rejecting. Why is it rejecting? I had a doctor, somebody that asked me about the infection that they deal with like half minutes before this webinar starts. They're using this T code. Why is it not? But it's not paid. It's the correct T code, but there's not a YB. There's not an external course code, and that information is not available on an Excel.
True.
So that is an option, but it's not a good option.
Yeah.
You don't know how to do it. The only other option is books.
Okay.
And the books come at a price tag of $600 a set. You need to import them, and very often they're not available because the WHO is working on a new set of ICD that will be called ICD11. Don't stress about it now, please. It's not here yet.
I'm going to interrupt you there. I wonder, while Yolandi's got an EZMed screen open in the practice management system, a question that often came up is these unspecified codes, and it's very often the 0.9 codes. Yolandi, perhaps you could just show us if we use a 0.9 versus what type of other codes are available, and talk us through an example.
Yeah, so if I look at, let's say, speech therapist, we actually had a question about speech therapy using an unspecified code, and the example that was given to us was F80.9. So if I look at F80.9, it says developmental disorder of speech and language unspecified. And yet again, if you look at the notes, it says language disorder. That's all it says basically. If I use the correct coding or the correct ICD10 code and I type in F80, you will see I've got a lot more options. And now I can go to that specific, the example that the person actually gave us was speech therapist treating phonological, language, and auditory issues. So if I look at F80.0, it says specific speech articulation disorder. And if I go to the notes, I get a lot more information. So it actually tells you specifically what this code is for. And that, you know, that is exactly what Anna was talking about, is that specific coding. So you can use, Anna, just correct me if I'm wrong, do you use both of them or do you use only one of them?
We must be very careful to unbundle coding. I would not use the unspecified code with a specified code. If it's the same thing that you're talking about, you will code only the F80.1.
But you can use then more than one specified code.
Yes.
Yeah, well, so for example, the patient's got expressive language disorder and a receptive language disorder. Then you will code F80.1 and F80.2.
Okay.
Yeah, that makes more sense, no?
Can you only have one primary ICD10 code?
Yes, you always will have only one primary ICD10 code.
But you can have.
So in this scenario, you will decide which one of these diseases is the most severe, which one is the primary problem here. That you put in as your primary diagnosis, and then the other code automatically becomes a secondary ICD10. It's perhaps important to mention that the word secondary does not mean the second place. It doesn't mean number 2. It means everything after number 1. Okay, they're all secondaries.
Yeah, okay, all right. Yolandi, we spoke about the S&T codes and the cause codes that links with those. Is that perhaps an example you can quickly show us while we've got you on a screen share?
Yes, of course. I just quickly want to go, while we're talking, I just quickly want to go to another profile. So basically, another example that I wanted to show you was, let's say I had a cyclist seeing me, also a psychologist. I've got a cyclist that's seeing me. He had a huge accident.
Mm-hmm.
And sorry, Lani, you're my patient.
Using my name.
You're my patient. So you had a below knee amputation. And you're coming to see me for counseling because, I mean, there is a lot of adjustments. It's changing. Your whole life has changed. So if I look at, I obviously need to code for the actual counseling. So if I go to F43.2, adjustment disorders, right? So you will see with adjustment disorders, there's a whole bunch of notes. But what I wanted to actually point out is states of subjective distress and emotional disturbance, usually interfering with social functioning and performance arising in a period of adaptation to a significant life change or a stressful life event. And that is typically what happens. So if I code what I'm seeing this patient actually for, which is psychological trauma, and I now obviously want to code to say, why did this patient have this trauma? If I go there, I must just now think, amputation. Oopsie.
Check your spelling.
I need to check my spelling. So if I look here, traumatic amputation at knee level, and immediately if I look at this yellow indicator, I know that I need to have a secondary code. So if I look at traumatic amputation at knee level, if I add it onto my claim, obviously I need to find the external cause code. So why did you have an amputation? So if I put in cyclist, non-traffic accident, you are very fit and you were doing a sporting activity, I can write all the keywords there, and obviously my V codes will appear to indicate to me which one do I need to use to add onto this claim. So now I can dive deeper again into the notes. I can add my S code, and at least the medical aid will also see now that I'm actually seeing this patient for a depressed disorder or a traumatic event, but he's having this traumatic event because of this life-changing experience that happened. So if I put in there, let's put in there 202, just to get some more coding, you will see I obviously have now, I don't have any warnings to indicate that this ICD10 code is not correct with this procedure.
But you've got both your primary code and your secondary.
For the diagnosis. Exactly. I've got the correct primary code. And that is what we really need in systems, is the fact that the system also needs to, it doesn't dictate, but it assists the practitioner on correct billing.
Thank you so much, Yolandi. Arna, while I'm seeing the code there, and I know we looked there at ICD-10 and procedure codes, a code and a description. This is a question that keeps coming up. When you submit claims to medical schemes, do you include the description of the ICD-10 or only the code?
Only the code, okay? By law, you're not allowed to put the description of an ICD-10 code on a claim. It is breaching patient confidentiality.
Okay.
And I realize that a code is as good as Dr. Google. But then the onus of the person breaching the confidentiality is not on you. Then it is on the person doing the Googling to find out what it means.
I think so Yolandi is trying to show it to us there as well.
Yeah, exactly. Yeah, so this is typically severe. I don't want Lani to know that I've got psychotic symptoms or bipolar disease or whatever. So accidentally, maybe I'm working and my medical claim is lying on my table because I paid the psychologist and I need to claim back from the medical aid. I don't want the wording on my medical claim. I only want the code because I don't think she needs to know I'm bipolar kind of thing, you know, no offense to anyone, but I mean, you know, so yeah, it's unethical to have your description on your medical claim.
And it's not a requirement from the medical schemes. It's
no. And also from electronic switching point of view, we switch only the code, not the description.
Excellent. Thank you. Yolandi, is there anything else you want to show us on the system while you're screen sharing?
Well, basically, I just want to show you as well what it looks like on claim level, just to give you an indication that the description is not visible on medical claims, and this is exactly what it should look like. If it just wants to, our internet's a little bit slow today. So if it downloads, I can show you. So you'll see there it only shows the coding and not the actual description of the ICD10 code.
So the procedure code description is showing, but not the ICD10 code. I think that's something to note in this example.
Exactly. But also in the PMA that I'm showing you now, you can also change your descriptions. So we actually help the practitioners or enable the practitioners to change the description of the code. So you don't, this is the published descriptions. So you have the ability to change that so that it doesn't say the whole long description of what that procedure code consists of. Yeah.
Excellent, excellent. Thank you so much. Can you believe it's 4 minutes to 5? Yes, we need to start wrapping up. There's a lot of questions.
I tried to answer some of the questions as fast as I could, and I realized I didn't put the sound off.
Shame, Adna. Thank you so much for that. There's a lot of questions that came in around where can I find the ICD10 codes? Where do I get some training? Just quickly around the training. We do a lot of ICD10 training. A lot of it is actually presented by Adna herself. Sometimes it's via Zoom platforms, sometimes it's face-to-face, sometimes it's just online platforms. And you can access more information on the DAXA platform. That is our DAX Academy of Learning. Yolandi, if you don't mind adding that website for me in the chat functionality.
Oh, definitely.
Perfect. That'll be great. And then maybe while you're doing that, Yolandi, also just add all 4 other places where people can listen to this webinar again, because it keeps coming up. It's on our website, under the webinar tab, it's under YouTube, podcast, and under Spotify. And Yolandi will add that information for you under the chat functionality, so you can just copy and paste it from there. I think this is an increasingly informative session, especially building up from the first one. Just to share with all of you, we will share Adna's top 10 or top 11 tips with you. We're also going to include some communication from FISC, as well as the South African Coding Standards and Guidelines document. You'll be able to find all those documents under today's date, under the webinar tab. We will just include all those documents there for you to view.
Lani, also included there, I mean, it's the FISC and the government standard, so you'll have both of them.
Wonderful, thank you.
Yeah, that's in. The other document that's also in there is actually the WHO guideline. When they gave it to us, it's like there. And yeah, I've tried to put in all the first addendums on coding COVID to see. You'll find
you're the best. You're the absolute best. Thank you so much. And thanks again to SpaceNet Global Group for sponsoring this afternoon's webinar. Again, should you wish to try EZMed or Medici, they are both for free to use. And if you just need more information about coding, where you can find it, we have got other systems available as well. Please contact us on the website via ezmed.solutions. We hope to see you all here again next week. That'll be the 27th of August. It's going to be a fascinating discussion. We've got the Netcare Group CEO, that is Dr. Richard Friedland, and he's going to come and talk to us with regards to his positioning on COVID, during the COVID pandemic, as well as what's happening after the COVID pandemic. Is there going to be something like an after, or is COVID going to be with us the whole time? We're going to hear what he's got to say. He's also going to share some of his pragmatic approaches that they took with regards to some of the interdisciplinary and the multidisciplinary teams that they had in their hospitals. And I'm just going to pick his brain on quite a few other subjects as well. So please join us, register under the webinar tab, and we really hope to see you next week. Adna, one sentence from you, and then Yolandi, you, then I'll wrap up.
I'm looking at all these questions now. I wish I could answer all of them, because all of them is valid. The big answer here is training. If once you understand coding, coding is easy. Talk to us, talk to Lani. we can set up a huge training session and you can all listen to me and I'll babble on for
forever.
all day.
Yolandi, over to you. What's your closing remarks?
Make sure your PMA is simple and helps to ease the pressure surrounding miscoding.
Thank you. And so that you code clinically, ethically as well.
Exactly.
Guys, thank you so much. Ladies, it's been an absolute pleasure hosting you two weeks now, or 2 sessions. Thank you so much. Hopefully we can do it again. I just want to leave all the attendees with one last thought. I thought, and this is something that I read on social media, so I can't claim it. I thought that 2020 would be the year that I get everything that I want. Now I know 2020 is the year I appreciate everything I have. Keep that in mind until we meet again next week. Thank you. Stay safe and stay within the level 2 regulations. Bye.
Bye.